Hey guys, so today we'll discuss how to do a cardiovascular system examination. First of all, we'll do a general examination. In cardiovascular examination, general examination differs somewhat. So while taking BP, we have to take BP in all four limbs. As in some diseases, the BP in upper limb and lower limb differs. Like in aortic regurgitation, BP in lower limb is more than upper limbs. Like in coarctation of aorta, upper limb BP is more than lower limbs. Takayasu disease, BP in all four limbs can differ, and in peripheral vascular disease, BP in upper limb is more than lower limb. Okay. Then pulse. So pulse will see rate to look for tachycardia or bradycardia. Then we can look for rhythm, as rhythm can be irregularly irregular. Patient would be having AF. Okay. Then we'll look for volume, character, then radio-radial delay, which can be there in Takayasu. Also radiofemoral delay, which can be there in coarctation of aorta or Takayasu. Okay, and in the end, peripheral pulses. Clear? Then respiratory rate, and the last thing to look in general examination in vitals is JVP. Okay. Normal JVP is 6 to 8 centimeter of water. So we can say up to 3 centimeter above the sternal angle or 8 centimeter above RA. Okay. So if JVP is more than 3 centimeter above sternal angle, then we call it as ASCD. Also in JVP, apart from the height, we have to look for the waves. Generally, JVP is biphasic. We have two waves and two descents. First upward wave is a wave, then we have X descent, V wave and a Y descent. Okay. So in normal JVP, A wave is more than V wave. Also, we have two waves. Suppose if A wave is absent, then the cause is atrial fibrillation. Okay. We have to look whether A wave is more than V wave and both the waves are present. Okay. Now, another part of general physical examination had to be done head to toe. Okay. So apart from pallor, we'll look for signs of AR and signs of I. Okay. Apart from like pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. So first we'll see these. Why pallor is important in cardiovascular examination is that anemia can itself cause high output cardiac failure. Also, sometimes murmur can also be there in anemia, which are systolic murmurs, mid-systolic murmurs. Okay. Icterus can be there because of right heart failure, congestive hepatitis, or cardiac cirrhosis. Then cyanosis can be there because of cyanotic heart diseases. Peripheral cyanosis can also be seen in heart failure. Okay. Clubbing. Clubbing can be there because of congenital cyanotic heart diseases or reversal of shunts in acyanotic diseases or because of infective endocarditis. Then generalized lymphadenopathy. Generalized lymphadenopathy is generally rare in cardiac disorders, but it can be seen in sarcoidosis or suppose someone having tubercular pericardial effusion or malignant pericardial effusion. Then pedal edema. Pedal edema Pitting pedal edema is a sign of right heart failure. So what are the clinical features of left heart failure and right heart failure? For left heart failure, we have this triad of dyspnea, orthopnea, and PND. For right heart failure, we have this triad of raised ABP, pedal edema, and ascites. Now, signs of AR from head to toe. First of all, we have this lighthouse sign. So what happens in AR is there is systolic filling of major vessels with diastolic runoff of the blood from the major vessels again into the L. Okay? So we have this lighthouse sound in which in the blood vessels of the forehead there is systolic filling of the blood with diastolic runoff of the blood. So it appears like a lighthouse. Okay. Another sign is demiscid sign. Demiscid sign is head bobbing. The systolic filling of the major vessels and diastolic runoff leading to bobbing of the head, which is known as demiscid sign. And we have Landolfi's sign, in which there is dilatation and constriction of pupils. Okay. Becker signs, which is seen with the help of a fundoscope, in which there is pulsation in retinal arteries. Then we have this Muller sign, which is also known as dancing uvula sign. That is, there are pulsations seen in the uvula. Okay. Then we have this Corrigan sign, that is, which is also known as dancing carotid sign, or visible pulsations in the carotid arteries. In abdomen, we have this Rosenbach and Gerhardt sign. Rosenbach sign is palpable pulsations over liver, and Gerhardt sign is palpable pulsations over spleen. Okay. Then Waterhammer pulse can be felt. That is, there is systolic filling with diastolic runoff. So high volume pulse is felt. Okay. So this is known as Waterhammer pulse or mounting pulse. Then Quincke's sign can be seen in nail fold, where there are visible pulsations over the nail fold capillaries. Over femoral, we have these Durozius, distal femorals, and Trobes sign. Last sign is Hill sign, and this is the most specific sign for AR and the most important sign. So in Hill sign, systolic BP in lower limb is more than systolic BP in upper limb by 20. And with the help of Hill sign, we can also categorize the AR into mild, moderate, and severe category. The difference is 20 to 40. Then you can call it as mild AR. If it is 40 to 60, call it as moderate AR. More than 60, we call it as severe AR. Okay. Now we also have to look for signs of eye in general examination. So for signs of eye, we can have rod spots in eye, which can be seen with the help of fundus. In hands, we can look for genuine lesions, oscular nodes. Okay, so oscular nodes are tender papules, and genuine lesions are painless macules. You can also look for splinter hemorrhages in nail beds. Also, clubbing is also one of the peripheral sign of eye. Now, we'll come to the systemic examination. In systemic examination, we'll start with inspection. So first of all, we'll look for chest shape and symmetry and spine deformity. So suppose if a patient is having kyphosis or scoliosis, so there is no point of doing the cardiovascular examination then, because apex beat or any other like areas of the heart will be in different positions then. Suppose you are listening to a murmur in aortic area, but in this patient the aortic area would change. Okay, then we'll look for precordial prominence and apical impulse. So apical impulse is a very important thing to look for in the inspection part. The normal position of apical impulse is 1 centimeter medial to mid-clavicular line. Okay, and it is generally visible in one intercostal space. Okay? If it is visible in more than one intercostal space, it means that it is more than 2.5 centimeters square wide. So area is more than 2.5 centimeters square. Call it as diffuse apex. Okay? Now suppose normal apex beat is 1 centimeter medial to mid-clavicular line. Apical impulse. Okay. So what are the causes of non-visibility? Suppose we are examining the patient and apical impulse is not visible. The most common cause is that the apical impulse is behind the rib. Okay? So we will not be able to appreciate it. Then another cause is obese person. Then hyperinflated lungs like emphysema, pericardial effusion. Okay. Other abnormalities in apical impulse can be that it is shifted outwards, but horizontally it is at the same level. Okay. So suppose normal apical impulse is this 1 centimeter medial to mid clavicular line. Now it is shifted outward, but it is in the same intercostal space. Okay. The causes of outward shift is any disease leading to RVH. Okay. Suppose apical impulse is shifted downward and outward. In this, the cause is LVH, and the cause is eccentric LVH or volume overload LVH. In cases of concentric LVH or pressure overload LVH, apical impulse would be in the same position, like in cases of aortic stenosis or hypertension. Here, another thing to notice is that apical impulse is a finding of inspection, while when we'll palpate, it is called as apex beat, which is the finding of palpation. Then we'll look for any other visible pulsations. Like sometimes we can have epigastric pulsations in case of RVH, or we can have left parasternal pulsations in case of tricuspid regurgitation. Okay. Then we can look for distended veins, which can be because of SVC obstruction or IVC obstruction. We can look for any scar mark or any sternotomy scar because of cardiac valvular surgeries or bypass surgeries. Then we'll come to palpation. In palpation, first of all, we'll confirm the findings of inspection. Then we'll look for apex beat. Again, we'll confirm the position of apical impulse. Then we'll look for character of apex beat. Now, the character of apex beat can be tapping, sustained, which is also known as heaving, or ill-sustained, which is also known as hyperdynamic. Normal apex beat is 1/3 to 2/3 of systole. Normal apex beat is felt in the duration of 1/3 to 2/3 of systole. Tapping apex means the apex is feeling in 1/3 to 2/3 duration of systole, but S1 is also palpable along with that. In sustained or heaving apex, the apex beat is felt for more than 2/3 of systole. Okay, this can be seen in case of aortic stenosis, LVH because of hypertension, or HCM. Then ill-sustained or hyperdynamic apex means the apex beat is felt for less than 1/3 of systole. it is seen in aortic regurgitation, mitral regurgitation. Okay. And tapping apex is seen in mitral stenosis. Then thrill. So thrill, what is thrill? Thrill means palpable murmur. So suppose there is a murmur in mitral area or tricuspid area. So if that murmur is palpable, then we call it as thrill. Thrill generally indicates that the murmur is of higher grade. So thrill means that the murmur is of grade 4 or more than that. Okay. Another thing is that while palpating for pulsations or apex beat, we'll use the pulp of fingers. While in case of thrill, we'll use head of metacarpals. And for heave, we use base of metacarpal. Okay. But now, after thrill, we'll look for heave. So left parasternal heave can be because of two things, that is RVH and LA enlargement. Okay. So if heave is present along with apex beat, then it is because of RVH. If heave is not synchronous with apex beat, then it is because of LA enlargement. We can also check for pulses, and we can see that if heave is present in systole, then it is because of RVH. If it is present in diastole, then it is because of LA enlargement. Similarly, for thrill, we'll look if thrill is systolic thrill or a diastolic thrill with the help of pulses. Another thing to look for in palpation is that any other pulsations is felt or not over the precordium. Like epigastric pulsations can be felt in RVH, or pulsations in any other areas felt or not. We can also look for palpable heart sounds in palpation. Like palpable P2 pulmonary area can be there in cases of pulmonary hypertension. Palpable S1 can be there in mitral stenosis. Percussion. So generally for cardiac patients, we generally avoid percussion, but if asked to, we can percuss the left second intercostal space, because in patients with pulmonary hypertension, due to the dilatation of pulmonary artery, left second intercostal space, which generally is resonant, will become dull. Okay. Now let us come to the auscultation. In auscultation, we generally don't tell the auscultation of each and every area. We'll auscultate each and every area and then tell the final diagnosis, then the final results. Okay, so we'll tell about S1. We'll start with normal sounds. We'll tell about S1, whether S1 is normal, loud, or muffled. Okay, so how can we say that S1 is loud? Generally in mitral and tricuspid areas, S1 is louder than S2. In aortic and pulmonary area, S2 is louder than S2. Now suppose in aortic and pulmonary area also, S1 is louder than S2, and we call it as loud S1. Okay. Causes of loud S1 are any tachycardia, short PR, or severe MS, non-calcified. Similarly, we have to tell about S2, whether S2 is normal or not, along with the splitting. And we have to comment on P2 as well. Okay. So we have to tell that whether the splitting is normal or not, first of all. So for splitting, we generally splitting is heard in pulmonary area. Why? Because S2 is two component, one is A2, another one is P2. But P2 is very soft. So P2 is generally not heard in any area other than pulmonary area. First, so for splitting, we have to auscultate in pulmonary area. Now, I have to tell whether splitting is normal or we have wide splitting, then wide fixed splitting and wide variable splitting or paradoxical splitting. The causes of this we'll discuss further classes. Then whether P2 is loud or not. Because if P2 is loud, that means that pulmonary hypertension has set in. Okay. So how can we say that P2 is loud? So for P2 is loud, we have three things. Generally, splitting is not heard in any other area, but if you are able to appreciate splitting in any other area other than the pulmonary area, then P2 is loud. Other than that, in pulmonary area also, A2 is louder than P2. But if in pulmonary area, P2 is louder than A2, then also we can say that the P2 is loud. Along with that, if P2 is palpable, then we can say that P2 is loud. Now, after S1, S2, we'll tell about S3, S4, that whether S3, S4 are heard or not. Generally, if present, S3 and S4 are heard over mitral area, apex. And we generally listen for S3 and S4 with the help of valve stethoscope, as they are low pitch sounds. So in cardiology, we have four low pitch sounds. One is S3, one is S4, then we have tumor block and MDM of mitral stenosis. After S3 and S4, we'll tell about adventitious sounds, any other sounds which are heard other than S1, S2, S3, and S4. So in adventitious sounds, we have systolic adventitious sounds and diastolic adventitious sounds. In systolic, we have ejection click and non-ejection click. In diastolic, we have opening snap, pericardial knock, tumor block. Okay, we have to tell this. After that, we'll tell about the murmur. Murmur we have to describe in these 10 points. So we'll describe the murmur first of all with timing, like the murmur is systolic or diastolic. Suppose I am listening a murmur in mitral area, okay, and suppose it is a murmur of MS. So I'll tell that the murmur is diastolic, and also I have to tell about in which phase of diastole we are listening the murmur. So mid diastolic. You have to tell the timing of the murmur, that whether it is mid diastolic, early diastolic, pan systolic, ejection systolic. Then we'll comment on the grade of the murmur. So for grading, systolic murmur is divided into grade 1 to 6 and diastolic is divided into grade 1 to 4. Both have one thing in common, that if thrill is present, then it is a murmur of grade 4 or more. For systolic murmur, we have grade 1, that is the murmur is very faint and heard only with special efforts. Then grade 2, that the murmur is faint but audible. Grade 3 is murmur is moderately loud. From grade 4 to 6, thrill would be there. Along with that, grade 4 is a very loud murmur. Grade 5 is murmur that is extremely loud, that it is heard with one edge of the stethoscope lifted from the skin. Okay? And grade 6 is that the murmur is so loud that it can be heard with the stethoscope removed and it is placed 1 inch of the chest. In diastolic again, grade 4 thrill will be present, 1 to 3 thrill is absent. So grade 1 is a very soft murmur, grade 2 is soft, grade 3 is loud, but thrill is absent, and grade 4 very loud with present of thrill. Then we'll go for character. Character means how the murmur is listened to and what is the character or the quality of the murmur. Okay, suppose case of MS, we have a rumbling character of the murmur. In case of MR, TR, AR, the character is blowing. Case of aortic stenosis, pulmonary stenosis, the character is harsh. Okay. Then we have to tell about the pitch of the murmur. So generally, all the murmurs are high pitch, except mid-diastolic murmur. We have to tell about the configuration of the murmur, that what is the shape of the murmur. So suppose in aortic stenosis, the murmur first increases and then decreases. So it is known as crescendo decrescendo murmur or a diamond shaped murmur. In aortic regurgitation, the murmur is of higher intensity in the beginning and it tends to decrease. So it is a decrescendo murmur. Case of MS, the murmur decreases and then increases due to presystolic accentuation. The murmur is decrescendo crescendo. While MR, TR, the murmur remains the same intensity throughout, so it is a plateau. After that, we'll tell about radiation. The systolic murmurs are the ones which radiate generally. Diastolic murmurs doesn't radiate. And about radiation, the murmur of MR radiates into the axilla, or it can also radiate the base of the heart, depending upon the which leaflet is involved or the direction of the jet. The murmur of AS radiates to the carotids. Okay. After that, we'll tell about the murmur is best heard with diaphragm or bell. So generally, high-pitched murmur are better heard with diaphragm, while low-pitched murmur are better heard with bell. Then we'll tell about the patient position. For patient position, murmurs in mitral area are better heard in left lateral position. Murmur in tricuspid area are better heard in patient lying supine. Aortic and pulmonary area murmurs are better heard with patient in sitting position and leaning forward. Okay. Then we'll tell about that the murmur is best heard with breath held in expiration or inspiration. So generally, right-sided murmurs are better heard with breath held in inspiration, and left-sided murmurs are better heard with breath held in expiration. Then we'll tell about dynamic auscultation, that murmurs increase or decrease with Valsalva, standing, hand grip, or leg raise. Yeah. So in these 10 points, we have to describe about the murmur. After that, we have to tell our provisional diagnosis. The format of provisional diagnosis in cardiac system is, first of all, we have to tell that whether the disease is acquired or congenital, what is the etiology, like rheumatic or cardiomyopathy or ischemic or congenital. Okay. Then we have to tell valvular involvement. Suppose it is a case of rheumatic heart disease, we have to tell whether which valve is involved, like mitral valve is involved or aortic valve is involved or tricuspid valve is involved, and what is the lesion, whether the lesion is a stenotic lesion or a regurgitant lesion. Then we have to tell what are the complications, like whether PH, pulmonary hypertension, is developed or not, whether there are any signs and symptoms of congestive heart failure. If there is a CHF, then what is the NYHA grade? Then we have to tell whether IE, signs and symptoms of IE, is present or not, and what is the rhythm, like patient is in AF or sinus rhythm. So this completes our discussion. Thanks a lot.